speaker today. We will have Dr. Mazen Sinjab. He will give first talk. Then we'll have Dr. Sharif and Dr. Yahya, then Dr. Sharif. They will give a talk about the first episode of Cataract series sessions. And this is the first. And I'm also honored to have Dr. Brian Kim and Dr. Zainab from United States to be with us as panelists. Thank you for all of you. And I hope that you will enjoy today the discussions. And if there is anyone want just to share with us his opinion or to discuss or to ask a question, just he can either to send a question or to raise the hand, and we can just give him the mic to talk with us and discuss lively. We are going to have a series of actually a cataract series about 8 episodes. So it will be not every week. So we will have one time cataract anterior as an anterior segment. Then we'll have another week, or it will be a posterior segment. Then we go going back to anterior segment like that till we finish that one. And also in the posterior segment from the next week, we will have also like a series in a different topics in retina and other subspecialties in posterior segment. I think we are going to have the first talk, and it will be by Dr. Mazen Sinjab, my dear friend, Dr. Mazen. He will give a talk about exceeding expectation for dry eye patient. Dr. Mazen, please.
Bismillah, assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, everybody. Thank you, Dr. Muhammad, for the invitation. And I'd like to thank Allergan for inviting me to talk about this. And this is my financial disclosure. I'm receiving an honorarium from Allergan for the second part of this presentation. Now, the first part of the presentation is purely scientific. I'm going to talk about the pillars of healthy ocular surface, which consists of the balanced nervous system, functional corneal nerves, balanced hormones, normal lacrimal gland, normal vasculature kinetics, normal eyelids and blink rates, pivotal meibomian glands, and normal conjunctival goblet cell. Okay, we all know that there is something called the ocular surface disease, but the ocular surface disease has plenty of manifestations. Part of it is dry eye. We cannot say that ocular surface disease means dry eye. It is just part of it. Other manifestations include meibomian gland dysfunction, which is usually associated with dry eye disease. There is also meibomitis-related keratoconjunctivitis, neurotrophic keratopathy, anterior blepharitis, allergic conjunctivitis, corneal epithelial basement membrane dystrophy, conjunctivochalasis, keratoneuralgia, computer vision syndrome, pterygium, and recurrent corneal erosion syndrome. In this lecture, I'm going to highlight very important tips which are important for general ophthalmologists regarding the first 4 diseases. Now, regarding the dry eye disease and meibomian gland dysfunction together, I'm going to talk because they are usually associated. According to Tifos Deuce 2 report, the definition of the dry eye disease is a multifactorial disease of ocular surface, which is characterized by loss of homeostasis of tear film, which leads to tear film instability and hyperosmolarity, causing inflammation and damage to the ocular surface. In addition, it is associated with neurosensory abnormalities. Now, the classification of the dry eye disease, according to the Tifos Deuce 2, is evaporative dry eye and the aqueous deficiency dry eye. But actually, there is no pure one of them. They are mixed, more or less one of them. However, the most important components of the, let's say, this vicious circle of the dry eye disease are the lacrimal secretions. Usually we find low secretions, meibomian gland dysfunction, and the a compromise of the goblet cell in ocular surface. This is the cascade, inflammatory cascade that we see it in the ocular surface disease in general, which usually starts with hyperosmolarity, especially if it is dry eye disease, then tear film instability causing cell stress, and after that cell death, then the inflammatory process will be initiated in, let's say, two modes: the innate immunity, cytokines, chemokines, MMPs, and the adaptive immunity, where or in which the lymph nodes are involved, causing inflammation and again the vicious circle. But the inflammation will cause epithelial disease, corneal barrier disruption, neural sensitization, and loss of goblet cells. Great. Now, there are risk factors of the dry eye disease. Some of them are consistent, some of them are, let's say, not consistent. Like the consistent ones are age, gender, meibomian gland dysfunction, connective tissue diseases, Sjogren syndrome, androgen deficiency, screen use, contact lens wear, estrogen replacement therapy, because let's say that androgen, when it goes down, then there will be dry eye. Estrogen would go, when it goes up, there will be a dry eye. Hematopoietic stem cell transplantation, certain environmental conditions and medications. I want to highlight the Sjogren syndrome. We have to ask the patient about the symptoms and to look for the signs of Sjogren syndrome in every patient suffering from chronic dry eye, because let's say 10% of the patients they have underlying Sjogren syndrome. And in a meta-analysis of this disease, it has been found that almost 20% of people having primary Sjogren syndrome are associated with malignancies. So it's very important to diagnose this disease very early and by referring the patient. So what I'm usually doing when I find a patient with very chronic dry eye disease, and even if I have a doubt of Sjogren syndrome, I refer him to rheumatologist in order to figure it out. The other one I would like to highlight is the screen use. Nowadays, we are online school, we are online work, so it has a very big role. The other factor is the contact lens. Where, of course, we have to ask the patient, especially females, whether they are wearing contact lenses, especially cosmetics. Now, the other thing is the certain environmental conditions, especially if the patient is exposed to high-speed airflow during sleep or in the office, or even driving the car. The air conditioner is usually directed towards the face. High exposure to ultraviolet, air pollution, high heat index, and proximity to salt water. The nature of the water that we are taking a shower with it, for example, affects the dry eye disease. Now, the probable risk factors include the diabetes, rosacea, viral infection, thyroid disease, psychiatric conditions, pterygium, low fatty acid intake, refractive surgery, allergic conjunctivitis, and medications. Medications responsible for the dry eye disease are anticholinergic, diuretics, beta blockers, antihistamines, and anti-glaucoma. So it's very important to prescribe lubricants to people having anti-glaucoma medications, because this is a chronic use of anti-glaucoma medications causing a dry eye disease and causing incompliance to the anti-glaucoma drops. Now, the inconclusive risk factors, some ethnicities, menopause, acne, sarcoidosis, smoking, alcohol, pregnancy, Demodex infestation, botulinum toxin injection, sometimes multivitamins, oral contraceptives. We know that the impact of the dry eye disease is it affects the topography, it induces high order aberrations, it affects visual acuity and refraction, changes the K readings, it changes corneal thickness, and all of this will lead to inaccurate biometry before cataract surgery, and it will cause dissatisfaction after premium IOL implantation and dissatisfaction after laser-based refractive surgery, because we know that the tear film instability will lead to irregularities on corneal surface, and in addition to sometimes hypertrophy of the epithelium, or sometimes thinning of the epithelium, and sometimes irregularity of the epithelium, high order aberrations, as you see here, instability of vision, blurring of vision. In addition, that the inaccurate K readings, and therefore the inaccurate, let's say, the biometry. So it's very important words to give the patient before doing the biometry, every patient, to give a lubricant for at least 1 week, even if the patient is not suffering from the dry eye disease, because almost 80% of patients coming for cataract surgery, they have asymptomatic, non-symptomatic dry eye disease. Now, regarding the diagnosis of the dry eye disease, the best test is to go for the osmolarity, because it is the most accurate one in comparison with the other diagnostic tests. And according to the TIFOS-DUS2, the diagnosis should be put by having symptoms in addition one of the following markers. So if there are no symptoms, it is not a dry eye disease. It may be other, let's say, ocular surface diseases. So there must be symptoms in addition to one of the following markers: the non-invasive different breakup time, the abnormal osmolarity, or ocular surface staining. Now we come to the osmolarity. These are the cutoff values for the osmolarity above which, let's say that the patient has a dry eye disease. This is corneal staining and ocular surface staining and lid staining. We have to put this in mind. It is defined as having more than 5 corneal spots or more than 9 conjunctival spots, or the lid margin has more than 2 millimeter length. I'm sorry for the voices coming from here and there. Okay, and okay. We come to the severity of inflammation. Every case of dry eye disease is associated with with inflammation, according to the definition by the TIFOS-DUS2. So this test does not diagnose dry eye disease. It just tests the severity of inflammation associated with dry eye disease. You all know the cutoff values. I'm not going to talk about this, but the very important neighbor that we have to take care of is the meibomian glands. We know that there is a disease called meibomitis-related keratoconjunctivitis affecting the cornea, and let's say that the location of the problem on the cornea corresponds to those inflamed meibomian glands, as we see here in this picture. Okay, the wider the inflammation in the glands, the wider the problem on the corneal surface. Actually, it is, let's say it is classified into flectinular and non-flectinular. Sometimes it's severe enough to cause corneal perforation. And sometimes it's mild enough to be skipped when we check by the slit lamp. And sometimes we may think this like sequelae of herpes disease. So not every opacity with vascularization in the cornea are related to herpes. Sometimes they are related to meibomitis-related keratoconjunctivitis. Okay, so this is the flectinular type, where we find a flectin on the cornea itself, and this is the non-flectinular type, where we find just opacity, or sometimes we find generalized diseased epithelium. Now, according to this study, which is the most famous one in this regard, 2 groups were compared, normal and diseased group. The P. acnes were isolated in almost quarter of the normal people as flora, while the P. acnes consist 60% of the pathogens isolated in the diseased group. So we have to put in mind this pathogen in order to treat it. The neurotrophic keratopathy, in many cases, it is associated with a dry eye, and it is defined as decrease or absence of corneal sensation, which lead to, of course, it can be classified into normal, mild, moderate, and severe, and it will affect for sure the epithelium and the stroma. So it is classified into mild when the epithelial changes are without epithelial defect, moderate when the epithelial defect, there is epithelial defect without stromal defect, and severe when there is stromal involvement. And all of this is related to the severity of the loss of the branching and number of the nerve fibers. The clinical presentations of this keratopathy, when it is mild, it will cause only dryness and photophobia, inability to read for a prolonged period of time. Look at this symptom. It is very important. Many patients come and they say, whenever we read more than half an hour, we lose vision. We cannot continue. So most probably it is because of the neuropathy, impaired quality of vision, reduced blink rate. In the moderate and severe, there is the pain and discomfort are less or absent due to hyposthesia or anesthesia. Now we come to the peers in the management of the ocular surface disease. You have to listen to the patient. You have to spend time with the patient, listening to the symptoms. In addition, you have to look at the eyes of the patient while they are talking, because you may figure out some symptoms and some signs like loss of or a low blinking rate, for example. We have to check the corneal sensation in every patient who is suffering from dry eye disease. And we have to test the 4 quadrants. In addition, we have to test the conjunctival sensation. It's not only the corneal sensation. Corneal staining is mandatory for all cases. And if it is superior in the cornea, we have to be suspicious because it might be because of flappy eyelid, changes on the palpebral conjunctiva, superior limbic keratoconjunctivitis, or contact lens induced limbic stem cell deficiency, such as in this case, which is caused by the contact lens. Of course, we have to emphasize and provide clear instructions on lid hygiene. And whenever we see this, we have to have a doubt about the Demodex. We have to use anti-inflammatory therapy as early as possible, only when indicated. It should not be as a habit. It should be only when indicated. Of course, the anti-inflammatory therapy consists of, let's say, a wide range of products. The cyclosporine, which inhibits T cell activation and reduces inflammatory cytokines. It increases tear production, goblet cell density, and corneal sensation. The levetiracetam, which is a LFA1 antagonist, it increases as well tear production, goblet cell density, and corneal sensation. Topical steroids, which suppresses inflammation broadly, but the limitation is IOP, elevation, cataract, and infection. Therefore, topical steroids can be given just for a very short term in the beginning of the treatment. Of course, tetracycline and metalloproteinase inhibitors, they have a role. Tacrolimus has a role. Systemic antibiotics and macrolides have a role as well. We have to minimize preservative toxicity. We have to manage patient expectations and be persistent, and we should give them self-support by reassuring them that they will improve. I always advise to use a questionnaire in order to test the like the improvement of the symptoms. There are 2 types of the questionnaires, and we have to remember the neighborhood. It's very important when patient is suffering from dry eye disease. We have to check the meibomian gland dysfunction, especially when we see some lesions on the cornea. Now, this is part 2, which is related to allergan, including the Restasis. Of course, we said that the Restasis is an anti-inflammatory product, and actually it affects and cuts the cascade of inflammation. It also increases the tear film production as per studies. It increases, or let's say improves the tear film breakup time over time, and it changes the corneal staining. Sorry, it changes corneal staining. It reduces corneal staining, which means more vital epithelium, and it increases the goblet cell density. I'd like to present these 2 cases, which I presented before, but because Allergan asked me to present them, I'm presenting the first one. 48-year-old female suffering from chronic dryness, redness on and off, irritation, blurring of vision on and off. Vision is 20/20 with her glasses, and no systemic diseases. I did the investigations that everyone does in the clinic, like corneal staining, tear film breakup time, Shermer test, OSDI, and the MMP9. There was no corneal staining, but the tear film quality was very, very bad, as you see here. From just after blinking, you see this picture. And this is the tear film breakup time, then the non-invasive. Shermer test showed 7 millimeter in the right eye, 8 millimeter in the left eye. And this is the questionnaire, which gave a score of moderate to severe, okay, moderate to severe dry eye, according to this questionnaire. Now, I put the patient on Restasis for 6 months, and then I tested again the same investigations. The tear film breakup time very much improved. Shermer almost same as before the treatment, and the questionnaire showed a very good improvement in the severity of the dry eye disease. So it was moderate to severe, but after treatment, it became mild, according to the questionnaire. This is another case, which is a 32-year-old male suffering from chronic dryness, redness in most of the time, fluctuating 20/20 unaided, and no systemic diseases. The same investigations, corneal staining, tear film breakup time, Shermer test, the questionnaire, and the test for the severity of the inflammation. This was the corneal staining, generalized punctate epithelial erosions, which means diseased epithelium. Of course, this is one of the criteria. We said that more than 5 dots are to include the patient. Shermer test was very low, 5 millimeter in the right eye, 4 millimeter in the left eye. And the questionnaire showed almost severe dry eye disease, okay? Almost severe dry eye disease. I put the patient on Restasis for 6 months, and then I checked the staining of the cornea. This is before and this is after. Very much improvement in the staining, although the Shermer test stayed as before. So Restasis improves the quality of the tear film, even if the quantity of the tear film maybe does not change. And this is the questionnaire of this patient. This is before and this is after. So the patient moved from the almost severe to mild to moderate of dry eye disease symptoms. And thank you very much.
Thank you very much, Dr. Mazen. Very interesting and, as usual, a good presentation. There is so many questions in my mind all the times. You know, ocular surface disease we are facing all the time. We are talking about dry eye all the time, but even still, the dry eye is one of the most, or ocular surface disease, one of the most important diseases that we are facing in anterior segment. And it is only not a dry eye. You know, when dry eye is one of the ocular surface disease. There is one question, it came to my mind when you are presenting, Dr. Mazen, how the dry eye affecting the corneal thickness. You said there is an effect on the corneal thickness. It came to my mind how. I just to know if you have an idea or.
Very good question. Actually, corneal thickness is affected by the outliers, which are the epithelium and the endothelium. Of course, the endothelium more effect. The epithelium, whenever it is diseased, it cannot protect the corneal thickness. And it has been shown by some studies that the diseased cornea, the diseased corneal epithelium causes some hydration of the cornea, causing, of course, increase of corneal thickness. Moreover, the epithelium itself, the thickness of the epithelium will be affected by the dry eye disease, chronic dry eye disease. It may go, first of all, it goes into hypertrophy, then it goes into irregularity, then it goes into atrophy, or let's say a thin, very thin layer of the epithelium. So in these two mechanisms, it is affected.
Okay.
Can I ask a question, Dr. Mazen?
Yes, please.
Dr. Mazen, thank you very much for excellent simplified presentation. But I want to correlate this with the cataract, and one of the most common correlations is meibomian gland dysfunction that we see increases after the cataract surgery due to the drops, due to the surgery, and this really annoys the patient. So what are your advices pre-operative in cases that they are borderline meibomian gland dysfunction, and what would you do after they elaborate and become really annoying to the patient?
Very good. Thank you very much. Actually, as I mentioned in one of the slides, that dry eye disease is a risk factor for inaccurate measurements of the IOL, and it is a major factor of dissatisfaction after premium IOL implantation in cataract surgery. So this is why it is recommended to give lubricant to the patient before doing the biometry. Now, in addition, we have to take the K readings. For example, the patient came and we gave lubricant and we asked the patient, please come after 1 week, and they came after 1 week. Now, we do the K reading measurements by the autoref, for example, and IOL master, or autoref and topography, or topography and IOL master. So 2 machines. If we find difference in K readings and amount of astigmatism, it means there is an ocular surface disease. So we have to test again, and we have to extend the period of the lubrication and the treatment of the ocular surface disease, whatever the background is. And then we check the patient again and again. So this is mandatory to treat ocular surface before doing the cataract surgery. Now, after the cataract surgery, yes, any incision, any operation in the ocular surface, cataract surgery is through the ocular surface. So in this case, usually the nervous system and the ocular surface will be somehow upset because of the trauma, and it causes an increase of the dry eye that the patient had before. So of course, we have to treat as well. We have to take care of this. So this is my answer.
But when the patient presents post-operative with severe irritation and full-blown, is it only lubricants, or would you give more
very good
drops, anti-inflammatory, systemic tetracycline, or?
Yeah, very good question. Now, let me show you these 3 slides, only 3 slides within 1 minute, to show you how treatment of dry eye disease should be staged in stages. It should be not all together to give everything together. So if you allow me just to share this one very quickly. Okay, now you can see the screen, right?
Yeah.
Yes, Dr. Safwan.
Okay, Dr. Mazen, I would like to be like Dr. Safwan, but unfortunately I cannot. He's better than me.
You are both my friend, no problem.
Okay, now step 1, education. Treat underlying pathology. Environmental modification. Modification of topical and systemic medications. Lubricants, lid hygiene, and warm compressors. This is stage number 1. So lubricants is a part of, but discussing all other factors with the patient is mandatory. Okay, this is step 1. Step 2 is step 1 plus the followings. We have to put Demodex into consideration. Meibomian gland treatment. So we don't send the patient to the thermal therapy or blah, blah, blah from the first step. We have to modify everything related to the environment. We have to give lubricant. We have to treat the background. And then if no improvement, we can go to the step 2, which includes the meibomian gland treatment, topical anti-inflammatory medications, the steroids, cyclosporines, levetiracetam, and topical antibiotics like the azithromycin. Now, if this doesn't work, then we go to step 3, which includes step 1 and 2, in addition to punctal plugs. Punctal plugs comes in step 3, not in step 1. We must not put punctal plugs in every patient coming because of dry eye. We have to go through step 1, then step 2. Then if it is not useful, we can go for punctal plugs or sometimes autologous serum, bandage contact lenses, oral anti-inflammatory medications, like Dr. Yahya, what you asked about, the tetracycline, erythromycin, azithromycin with low doses of these antibiotics. So this is my answer.
Thank you, Dr. Mazen. Thank you. We have 3 questions, if you allow me, please, because we don't want to miss the time. Then I will come back to you, Dr. Safwan. There is a question from Dr. Ahmad Ali. During menopause, this for you, Dr. Mazen. You are not Safwan. So estrogen level is falling down. Could that be the cause of the dry eye? I didn't understand it much, but if you understand, can you give us?
Yeah, very good. Actually, this is controversial. Now, some studies showed that estrogen, high level of estrogen increases dry eye. Some studies showed no, low level of estrogen increases dry eye. So this is controversial. Let me say that any imbalance in the hormones will cause dry eye, regardless which is going up or which is going down.
Okay. Second question from my dear friend, Dr. Qasim Hamouri. He's having 2 questions. Do you have cause allergic to restasis? Sorry, do you have cases allergic to restasis? Sorry.
No, till now not.
Okay, I think there is is it recommended to give restasis continuously for 6 months as I mentioned?
Yeah, it is. This is the course of restasis. Yeah.
Okay. Then I have one question, Dr. Mazen, and this one can be for everyone here in the panel. Regarding using restasis, the age of the patient that we can use. So is it possible to use in children, and what is the age that we can use? Is there any different precautions we have to take care in while you are using that or not? Because you know, dry eye now it's happened in children. They are using laptops, they are using mobiles, so we are seeing a patient, they are having a dry eye.
Well, I'm not aware of studies of restasis on children. I'm not aware of. Maybe there is, but I don't know. But however, I don't think that dry eye is severe enough in children to develop meibomian gland dysfunction and all the manifestations that we see in adults. I don't think that, I have never seen a child like this. Yes, dry eye because of screens, because of low blinking rate, but not to the severity that restasis is recommended. This is my opinion.
So no, I don't mean it's only children. I mean, it can be also 15 years, 17 years, this one. What is the age now, if you want to give, when we can start using cyclosporine and treat it as an adult, let's say in this other way?
Personally, I'm not aware if there is a cutoff age, but usually it is in adults, which means above 18. But I don't know whether it is given to below 18. Maybe
okay, Dr. Azena, if you have or Dr. Brian. Yes,
yeah, I have. So again, I agree. I don't think there's really much studies to say when is the cutoff, but I've used restasis, I've used cyclosporin, I've used these are all topically. I've used topical tacrolimus in kids. So here in Texas, we do see pretty severe keratoconjunctivitis from meibomian gland disease in our Latin Hispanic population, to the point of, you know, even corneal perforation in these, 9, 10, 11-year-olds. And then, so I always want to try some steroid sparing agent, because you can't keep just putting them on topical steroids, of course, with the development of cataract, elevated pressure. The other young patient population I've used cyclosporin in is Tigasins as a steroid sparing agent. And there's, some studies in adults on that, but I've had a few patients that I've ended up being able to get off of steroids and putting them on topical restasis. So I'm pretty comfortable with, I would say I've treated 8, 9 years and above.
Problem, Zaina, it's that the ability of the continuing the treatment for those ages. Those ages, they are not willing to continue using the treatment, and restasis we needed 3 times for 6 months. So I don't think so that they can willing to to continue 6 months on this treatment.
It's definitely the compliance is definitely an issue, but luckily we have a lot of patients, parents that help. Yeah, definitely the kids aren't going to use them themselves for sure.
Is there any comment from Dr. Brian or any Dr. Sharif, Dr. Yahya about what we are here? We are having another comment from, yes, Dr. Brian.
I was just going to reiterate to what Zaina said. I mean, we have a pretty robust Hispanic population in Northwest Georgia as well. And I do see those patients with meibomitis, and, you know, they tend to develop chalasia as well and have this significant keratitis with corneal vascularization and so forth. So I do echo that. But with regard to the, you know, like the other issues mentioned about, you know, prolonged use of screen time and stuff. For me as a parent, I would say reduce screen time is probably my first recommendation.
Yeah.
You know, now there is a school teaching only from the far, you know, it's from home. They are mandatory to use this one, you know, it's not because of Corona these times, they are not going to the school, so they are just studying from home. It's what we are facing. Is there any comment?
Just
Yes,
one
Dr.
comment on that. We actually just submitted to Survey of Ophthalmology a review of kind of this whole concept of computer vision syndrome, you know, increase in, obviously with COVID, all the screen use. And I think Dr. Mazen Sinjab mentioned this, but we're finding that it's really has to do with the changes in blink rate. That is really what's affecting the younger population, because I agree, it's not necessarily decrease in, you know, lacrimal gland production of tearing. It's more evaporative, decreased blink rate, all of these things. And I agree with Brian, Kim, in terms of decreasing as much, but it's not realistic anymore. So I do think we should treat them. We should, you know, there's these 20/20 rule where you take a break from the computer, and, you know, there's a lot of behavioral changes that can be done, but it's definitely an issue now that we're seeing more often.
Zaina,
Okay, so
Dr. Muhammad, just two comments for you, Zaina, for your that's behavioral changes. What I'm doing for my patient is that I'm putting a stick on, if they are using the laptop or a desktop, a stick on it saying blink. So whenever they are seeing that stick, they will blink, and prevent them from using the phone after the blink, after the laptop or desktop, when they have any free time from in between the lectures. So apart from this, I just need to return back to comment on Dr. Yahya, what he said related to post-op treatment. I do agree fully that we are facing, most of us facing this problem after the cataract surgery, and the important issues is that behavior of the patient when they are sleeping. When we are reaching in our treatment to the antibiotic like azithromycin or tetracycline, and we are seeing that their condition will be improved for a while of time, 1 week or 10 days. And once we reduce the antibiotic, their condition will return back to the meibomitis. So my suggestion to them is to correct their sleeping way. That's a way that the eye will not touch their arms or their clothes or the pillows, because once that eye will touch the clothes or the pillow, the meibomitis, which and the main important bacteria that isolated from the meibomitis is that Campylobacteria acne, the gram-negative. That's the main issues that in creating this meibomitis as an infection. So important things to treat the patient or teach him how to sleep and prevent touching the eyelids to the pillow or to the clothes.
Thank you, Dr. Safwan. I need only a very short answer about the and comment. This is another comment, I think, rather than question, from Dr. Qasim Al-Hamouri. He said the recommendations 3 months, then you can monitor after that you can repeat the regimen for 2 months in maximum. I don't know if there is any comment about this one or not. He is mentioned that it can be recommended, the drugs recommended for 3 months.
I think that Dr. Mazen, he will answer.
What I know, what is recommended from the studies is 6 months. This is what I know, not 3 months.
Yeah, the first recommendation, it was 3 months. That's
okay, I have another, okay. Okay, Doctor. Can we? This is another comment from Dr. Usama Ababna, is our also dear friends from Jordan, Professor Usama Ababna. My friend, he said, I prefer to keep Restasis as the last line treatment for dryness and not as the first line. There are many drugs that can be used initially, and in severe cases, Restasis will be your choice. Is there any comment about this one, Dr. Mazen?
I totally agree. We should not start the Restasis or other anti-inflammatory from the beginning. This is why I showed the 3 slides, the staged treatment of the dry eye disease. And of course, treatment of the underlying causes and the treating let's say, other things that may complicate the case. For example, the neurotrophic, the begomitis-related keratoconjunctivitis. So all of that should be treated together, not only just giving Restasis from the beginning.
I think there is many other comment and question, but my dear friend, Dr. Brian and Dr. Zaina, they already answered them. So now we want to move to the next sessions and to the first episode of Cataract that we are going to conduct it during or through our coming webinars. And the first talk, it will be today by Dr. Yahya, and he is Dr. Yahya Salahuddin, and he is going to talk about different types of cataract that we are dealing with. So Dr. Yahya, the mic with you. You are mute, Dr. Yahya. So please, can you unmute yourself?
So the screen is shared. Thank you, Dr. Muhammad. Thank you, everybody. It's the first time to give this presentation. And this is actually an introduction to the whole episodes of cataract we're going to talk about in the coming month. And I asked myself, why? Why, if it is cataract, we all know the types of cataracts, but if you are a beginner, if you're starting, you really should know that there are so many different types of cataract. There are techniques, details that we should know. There are complications that we should anticipate in some cases. There are extra tools needed in difficult cases. Choice of IL can be a problem in other cataract cases, post-operative expectations. So there are a lot of things to know about types of cataract, which can be congenital, developmental, senile cataract with all its type. We can deal with traumatic cataract, uveitic cataract, subluxated cataracts, and others, many others. Almost not all cataracts are the same. So if you're starting, usually as residents, everybody would like, he says, I want to do cataract, I want to do phaco, but really you should consider many things. And one of the, in senile cataract or pre-senile cataract, the locus classification is good to document. It's good for documentation and understanding and correlating the vision and the severity of the cataract that the patient have. And it's very useful if we're doing research. But we have to learn more about the clinical examination to detect if it's peripheral cataract, is it central cataract, is it posterior subcapsular, is it affecting the whole nucleus and its nuclear, dense nuclear, mature cataract, intumescent cataract, everything we are going to talk about. So I'm going to get through in a not very complicated way, because we are going to tackle each of the topics separately later on in the episodes, not today. Today is like an introduction, but I just want to highlight for our younger colleagues how important their understanding of which cataract they are going to operate on. One of the main cataracts that we can see are soft cataracts, whether it's in a young person or you're doing refractive lens exchange, or even in older patients. Many times we see softer cataracts. And one of the things that we used to say when we teach cataracts, we tell that we don't want the beginners to use soft cataract. And the main thing you should understand why we were saying this, and we can correct this actually, and we can start with it. There is no cracking. The soft nucleus, you cannot do the manipulations you're going to hear about nucleus management. Actually, the whole key of soft cataract is lot of hydration, hydrosection, hydration of the nucleus. Then it is a very simple procedure, and actually it's very suitable for a beginner if you use the correct technique, because then you don't need to be so much mastering of the foot switch or the techniques of cracking and dealing of the nucleus. So as a start, the soft cataract, if we understand what makes it difficult and what makes it easy, then you can proceed. Let's move on and more immature cataracts, nuclear cataracts, grade 2 or 3. These are ideal cataracts. We used to tell our residents, these are the ideal cases that you can perform the different techniques of nucleus management or disassembling the nucleus. So if you are going to operate in such cases, you should really understand very well the machine setup. You should be very comfortable using the machine. Remember, as we are going to talk through this later on, that the phaco machine, you have to master it even before you start doing the surgery. It's like driving a car. You have to have your foot switch is the key of manipulating and maneuvering inside the eye. The foot switch is exactly like the gas pedal in the car and the brakes. You can maneuver with a car in a crowded city like Cairo, for example, if you are good enough to use the pedals and you know how to change speed and move smoothly between the crowded cars. If you don't know, you are going to crash and have an accident. And this is exactly the same. Learn very well. If you're moving to this type of cataract, you will need to do different types of nucleus management, whether divide and conquer, nucleus chopping, horizontal or vertical. All this we're going to talk about in different episodes. But to do this, you have to master the foot switch. You have to correlate your hearing and seeing and feeling with the settings on your machine. So let's move to a more difficult case. Once you get comfortable in regular case like nuclear 2, nuclear 3, you master the technique, you're getting better, you're getting more ambitious, and you want to do more difficult cases, you will see, and this in our part of the world, we see these types of cataract very often. So I'm going to tell you that there is a subset called intumescent cataract. The intumescent cataract is a sort of mature cataract, but the lens is swollen. The intumescent cataract can be white. And if it is white, usually the nucleus is not hard, but it can be brown as well. You have a black, very dense nucleus. The key in intumescent cataract is to break what has changed in such cases. Again, these are just, I'm giving you highlights, and we're going to elaborate on this later on in other episodes. But you always think when you move from one type of cataract to another type, more difficult, you ask yourself, what is making this lens different? What is making it more difficult? Here, intumescent cataract is the contrast and the high pressure inside the capsular bag that will tend to extend, and the main issue in intumescent cataract is doing a proper capsulorhexis. So as a surgeon, you have to prepare capsular stain, should be available from the beginning of the surgery to do proper capsulorhexis, and with different techniques to avoid the extension of the capsulorhexis, which is actually the major difficulty in such cases. So what I want to tell you that you by gradually you are building your knowledge, knowing which type of cataract you're going to deal, anticipating what you need in such cases and what the problems are going to be, so as you can plan properly and you can do your surgery properly. So we move on into black cataracts, and still we see these black cataracts. You have issues of the visibility of the capsule. You have to prepare capsular stain. You have an issue. This is what is different from nuclear 2 or 3, which you have now been trained to do perfectly well. What is different? This is the question always ask yourself. You want in any difficult case to analyze what is different to make a difficult case converted into a regular case using the same techniques after solving the problem. The problem with these types of black cataracts, the nucleus is very hard, the nucleus is very thick, so you would think that you will need to use a lot more power. If you use a lot of power, too much power, you're going to insult the cornea. The corneal endothelium will be affected. So you should think, number one, how to manage the power by using techniques that minimizes the use of power and making it efficient and cracking the nucleus in different techniques we are going to elaborate about to decrease the power, decreasing the incidence of wound burns, and essentially protecting the corneal endothelium. These cases might take long time, but if you do it properly, it will have minimal effect on the corneal endothelium. So in such cases, you will need capsular stain, you will prepare it, you will know that you are using the machine very comfortably. Never go to such a case if you are not comfortable using the machine. Think of how to decrease the power. It's not only the measurement of the power, it is where you apply the power. And then you deal with the nucleus, protect the cornea, and use whatever special techniques you will need to get you into a safe position in such cases. Let's move to another case that you might see. It's these cases, two categories, the posterior subcapsular cataract or posterior polar cataracts. And observe here, these cases, we see it a lot. Patients come complain early. It looks like, if you don't examine properly, it looks like a very immature cataract. It can be, but it can be also harder nuclei. But the main issue here that you should differentiate between the posterior subcapsular cataract, which is actually benign, and the posterior polar cataract, and you can see on the right-hand side that this is very typical of posterior polar cataract. You have a regular edge of the posterior capsular opacity, and the thing about this, that inherently this patient would have weak posterior capsule, or in some more rare cases, absent posterior capsule in a congenital defect in that area. So what does this mean to you? You have to identify these cases preoperatively, because once you go into surgery and you identify and see this, then you will abstain from doing hydrosection. Don't do hydrosection, do hydrodelineation. The idea is that you identify, it's a cataract case, yes, but you identify there is a risk. So you modify your technique to avoid the risk, which is here, early posterior capsule rupture, because it's weak. And if you don't identify this, you can get into more serious problems that you don't want, only by identifying the proper type of the cataract. In the case of posterior subcapsular cataract, once you see that this is posterior subcapsular, it is not posterior polar, then you will do the whole case as it is. But sometimes in these patients, you will find an adherent fibrosis on the posterior capsule that you will need to do either peeling or posterior capsulorhexis. So if you go into such cases, operating in such cases, be prepared that you or your supervisor has the ability to do posterior capsulorhexis, which is a skill that you should learn over your training period, learning phacoemulsification. It's very useful, important skill to know how to do posterior capsulorhexis. Moving into another category of cataract or lens problems, subluxated lenses, and these are completely, you can see, complete different scenarios, and each scenario you have to deal with differently, whether it is senile, whether it's congenital syndrome, whether it's traumatic, whether it is whatever the reason. You will see so many scenarios, and in each scenario you will see a different type of subluxation, different extent of subluxation, and different density of the cataract that you are dealing with, and different situation, like the one here on the left, lower left, you can see This was traumatic, and you can see vitreous prolapsing in front of the subluxated lens even before you start your surgery. So you should plan and be ready in such cases to have the proper tools to have. You should prepare capsular tension rings, capsular hooks, iris hooks, whatever, 3-piece intraocular lenses that you might need. So very important that you study the patient before. You are now getting into more complicated cases. So you study the patient, anticipate what you're going to need. You don't need to be surprised inside the operating theater asking for a capsule tension ring or a Sayoni ring or a Ahmed segment or a capsular hook, and you don't find it and you start to panic. If you plan properly, prepare the tools, know the technique, and because I told you there are different scenarios, the scenarios you can see the subluxation pre-operatively and you can plan well, and you can have intraoperative subluxation. Either you missed in the diagnosis or you induced the subluxation. So plan well, see the condition of the patient, and ask to prepare the tools that you expect you are going to need. This makes a lot of difference. Even preparing the type of IOL, preparing the type of sutures if you're going to sclera fixate, preparing the micro forceps if you think you will remove the whole bag and you will need Yamani technique, for example. So it's very important to know subluxated lenses is not one type of surgery, not one type of scenario. Plan your surgery, anticipate problems, and be flexible. Pseudoexfoliation, it's something we read in the literature. It's very common in Scandinavia. Actually, we see it very commonly in our region, and you can have it in such pronounced appearance like this. You should look for it in older patients. And why we should look for it? Because you can expect narrow-pupil, difficult to dilate. You can definitely expect zonulisis, so you have to modify the settings, the height of the infusion, the technique that minimizes stress on the zonules. You can expect a hard nucleus. You can expect post-operative or pre-operative open angular glaucoma that you are going to deal with later on. So in such cases, identify what is the diagnosis, anticipate the problems intraoperative and post-operatively, and act accordingly. This is a very rare case. I presented many times now this case, and it's very interesting. If you look at this magnified picture, you can see all these fine lines. Actually, when I looked at it, I missed it pre-operatively. So when I looked at it at the beginning of the surgery, the pupil was perfectly dilated. I've never seen or have never noticed something like this. Sometimes you can see aberrant insertion of zonules, but I have never seen such zonules extending to the central 3-4 millimeters. And when I looked at the literature after the surgery, after I had problems, I learned this is called long anterior zonule syndrome. It is rare, but it's very important to identify. And since I had this case, I always look carefully and pre-operatively at the beginning of surgery to see the presence of long anterior zonules. It can be complete, like this case, or it can be partial, like more common cases. And why I was interested to know, because at the beginning of this surgery, I thought that my whole problem will be doing a capsular access without extension of the capsular access by the help of these long zonules. But actually, I managed to do a perfect small capsular access, but continuous. And I thought, okay, everything is done. But actually, and I think we will give an example. I will show this case in a later episode. Actually, after I finished and I started phacoemulsification, everything went wrong. Because as you can see, when I did the rexes, I didn't do it big, but I cut the insertion of the zonules. So actually, the bag became completely loose. So during the phacoemulsification, I found the bag was completely coming out. So I had to remove it, implant, in that case, an iris glow lens, posterior fixated. But the problem was also that this patient got into intractable glaucoma postoperative. And when I looked at the literature, these patients specifically, they have a high incidence of preoperative or post-operative open angle glaucoma, sometimes due to shedding of the this material of the sinews, like pseudoexfoliation, blocking the angle. So this
Dr.
is
Yahya,
very important.
you have because Dr. Brian he is having only a short time to be with us, and I want just to have a comment before if you continue. So Brian, I know you are going to leave us because you have another commitment and your patient in the clinic. So please, if you have something to say, whatever the Dr. Yahya is mentioned till now, any comment, then we will continue with Dr. Yahya and other friends' comment.
Dr. Yahya, I think you have done a marvelous job condensing the entire universe of cataracts and cataract surgery in this lecture. So I think I don't have much to add, but for the residents, I would reiterate the car analogy about driving. Not only are you using both feet, but you're using both hands. So when you're doing cataract surgery, don't neglect your secondary hand. You have to become facile, being comfortable doing intraocular maneuvers with both hands. So when you're learning cataract surgery, bear that in mind. Number two, just remember, as Dr. Yahya said, every case is different. And, some cases are easy, some cases are not. And so bear in mind that every case is a step-by-step learning process. And number three, as Dr. Yahya also said, recognize the potential pitfalls and challenges before you get into the situation. So prepare, plan accordingly, and study before you do the procedure. And of course, it's helpful to have mentors by your shoulder when you're doing new types of cases, different types of cases. Start off with a 1 to 2 plus lens. And then after that, graduate to the next level. I'm Korean American, and I did Taekwondo, martial arts. So, you start off with the white belt, but then you graduate to the yellow belt and so forth. So it's the same principle. You can't be black belt in one day, and learn from all your mentors. And one day you will become a black belt. That's all I have to say. Thank you.
Thank you, Brian. Thanks a lot. Thanks a lot for being with us. Thank you. Have a good day.
Thank you.
Thank you.
I'm almost finished. So we move to traumatic cataracts, and here you should ask yourself, is it an open globe or a closed globe? Is it blunt trauma or a perforating or a penetrating trauma? Is the anterior capsule open? Is the posterior capsule open, or both are open? Is there cortical material in the anterior chamber? If there is intraocular foreign body? So it's so many questions, and you will know by time that the traumatic cataracts again present in different ways, and you have to have a strategy, particularly timing of surgery. You do it with closure of the wound, the penetration, or you better wait for healing, avoiding infection, better IOL calculation? Would you, if the cortex is in the anterior chamber, would you implant primary with repair of the lacerated cornea or not? And always remember, any trauma cases, any open globe injury has a risk of intraocular infection, which is very serious, that you should prevent and look for to avoid. Another entity is uveitic cataracts. These are difficult cases. A lot of synechia. You can have shallow anterior chamber. You can have very tight pupil, synechia in the edge of the pupil or extending to the back of the pupil. More important than dealing with the cataract, understanding and having a diagnosis of which type of uveitis, because then you can decide timing of surgery according to covering with steroids, and there is no activity of the uveitis. There are so many intraoperative challenges to deal with: the synechia, shallow AC, which type of IOL you are going to implant, if any, to be compatible, biocompatible, and uveal compatibility is very important. you might need in many cases like Behçet syndrome or cases with posterior uveitis or pars planitis, you may need to do a pars plana vitrectomy. You might deal with glaucoma, preoperative or post-operative. There are many post-operative considerations. One of the most important things is the length you are going to use steroids post-operative, which is usually different than the regular regime you are going to use in regular cataract cases. So uveitic cataracts is another challenge that we're going to see. And lastly, but not least, the congenital or the developmental cataract, though they are very soft, but the main challenge here is, number one, preoperative biometry issue is related to the age and the growth of the eye, the type of IOL, where you are going to implant the IOL, and intraoperatively, the main challenge is doing a properly sized capsulorhexis that you control, and the technique, it changes in children because the capsule is very elastic and usually it gets larger than you intend, and this is something that you don't want. And the second important thing that we know, because in children and infants as well, the posterior capsule is 100% going to be opacified due to high healing power, then you should learn, and definitely in all cases of the childhood cataract, you should do primary posterior capsulorhexis wide enough so as not to be occluded. And if in younger patients below 3-4 years, you should also add anterior vitrectomy to decrease the post-operative inflammatory reaction. So these are particular cases, and actually it needs more experience to do than regular cases. So finally, in conclusion, what I know I want to convey here for younger colleagues, it is not just a cataract. More important, what type of a cataract? Thank you for your attention.
Thank you very much, Dr. Yahya. Really a very interesting and excellent presentations. You tell me we don't know what to say, but you say a lot. I mean, you talk about everything. Just we need only to clarify, and maybe we have to dig deep to each point that you mentioned, inshallah, in the coming episodes of Cataract. So now I think if there is any comment, Dr. Zeina, Dr. Safwan, Dr. Sharif, about the talks of Dr. Yahya, then we can proceed with Dr. Sharif.
I think Dr. Yahya covered
you are mute, yeah, Safwan.
the types of cataract, and once we go further into this, these different episodes, we'll see more details on what Dr. Yahya showed us, and I hope everybody enjoys these cataract episodes, inshallah.
Thank you, Dr. Safwan.
Comprehensive and in a very and very highly classified way. And as Dr. Sharif said, that we need to go through it in detail, inshallah, but it was presented in a very nice way, in a very excellent way. So I think that we can proceed and go to
Dr. Zeina, if you have any comments, please.
Yeah, no, I agree. I mean, I have a lot of comments on the separate topics, but I think it makes more sense to wait till each one is specifically presented. You know, the one summary point I would say is preparation is vital. And also now we have a lot of imaging technologies that can help us in kind of being more prepared, you know, especially for the younger surgeons. You know, knowing how much zonular loss there is, you know, not just doing a clinical exam, looking at the space between the lens and the iris, or looking for actual movement, but even looking at biometry. You know, if a lens isn't that dense, but the anterior chamber is very shallow, less than 2, that could kind of let you think that maybe the location of the lens is in the right position. Also, sometimes I like using my catalyst laser for the potential PSCs versus posterior polar cataracts, because you can actually see the imaging of, you know, if there is a break in the posterior capsule, so you're a little bit more prepared. And then, you know, decompression for the white cataracts, the needle decompression has really changed my management of doing those surgeries. So thanks so much. The talk was phenomenal, and so many great pearls.
Thank you very much for all. I think now we need to proceed with my dear friends, Dr. Sharif. Dr. Sharif, he will talk about logistic of starting, and then he will talk about phaco machine fluidics. Dr. Sharif, the mic with you, please. Okay, Dr. Sharif.
Hello, Dr. Yahya, Dr. Mohammed. Can you see the screen?
Yeah, okay, please, yeah.
Okay. So my talk is on how to commence and proceed with phacoemulsification. Of course, we all know for beginners, it is important to know the phaco-dynamics and what machine you are dealing with, because there are different and lots of types of machines. There are classic machines and there are advanced machines. And every resident who is going to start working with his phacoemulsification needs to know exactly how this machine is working and what's the difference between each type of machine if he's going to work on different machines. I prefer that he sticks to a certain machine until he improves his technique and goes through in different cases, and then he can later on choose to change the machine, because each machine has several advantages over other machines and some disadvantages as well. So it's important to know your machine quite well before you start your cataract surgery. And nowadays I see it's like driving a new car, and you have to read the manual very good in order to drive safely and drive properly. And then later on you can go faster and maneuver yourself with your car as you learn different using different settings inside your car. It's the same with the phaco machine. You have to work on your foot pedal and know what this foot pedal correlates exactly with the machine, and how you change from step 1 to step 2 to step 3, and what changes occur in the machine, the panel, and the setups inside the panel. Which setup are you going to start working on, and if you are going to change the setup during your surgeries, how are you going to do that, and what will this be effective in your surgery. And if you don't do this, you will end up, of course, crashing. And this is why you wonder, why am I, what went wrong with my surgery in the end. So phaco-dynamics, what is phaco-dynamics? By definition, it's the various functions of the machine and their interrelationships. The phaco machines have two main functions. The ultrasound, it delivers the ultrasound power, as well as it controls your fluidics inside the eye. So what is the power actually? It's the electric current passing through a quartz crystal, which will generate a vibration of a precise frequency. Exactly like these are the quartz crystals. And if you don't know, it's used inside the watches in order to regulate the time in an exact matter. It's used in the phaco handpiece to generate the ultrasound frequency needed for emulsification. The frequency of the ultrasound machine is between 30 and 60 kilohertz in different machines. High frequency equals better cutting, but more heat generation. In all machines, vibrations are fixed. So in order to modulate the power, it's by changing the stroke length. Power equals oscillations times stroke length, and energy equals the power multiplied by the time utilized. Phaco tip. Phaco tips, there are different types of phaco tips in phaco machines. We have different angles at the phaco tips. There is the 30-degree angles, there is the 0-degree angle, there is the 45-degree angles, and the 60-degree angles. Nowadays, most surgeons work with a 30-degree angle because it can go through all steps of the surgery without needing to change this phaco tip. In divide and conquer, if you are doing the groove, for example, you can go with a 45-degree angle. It's easier. It doesn't get blocked so easily. So it's easier to do the groove with a 45-degree angle. But as I said, that working with 30-degree angle can do the job as well. However, while going through with a stop and chop, use a 30-degree angle. Of course, bent tip now are used widely because with the introduction of torsional phaco, these tips are bent. So bent tips are used, as we see in the image down, in order to improve our phaco emulsification techniques by using the torsional technology. What about power and delivery? There are two types of power delivery. There is the linear, in which power varies from 0 to maximum according to the degree of depression in the foot pedal in position 3. You can fix the power if you want, but most surgeons prefer the linear rise in the power, which is controlled by the foot pedal. But if you want to change, to start with a fixed power and continue with a fixed power, you can do this also. And you reach this maximum power once you step into step 3 with your phaco emulsification foot pedal. What about the delivery? You can do a continuous power delivery, or you can use the phaco pulsed mode, and there is also the burst mode. In pulsed mode, there is variable on and off intervals in the delivery of the phaco power. Variation of the panel includes burst mode also, where depression in the pedal in the position 3 results in variation in time, in interval time. Both pulse and burst are aimed to decrease phaco time and hence the phaco energy as well. We move now to the fluidics, which is a very important step, if not the most important step. The fluidics are the integrated system of irrigation, aspiration in order to maintain the stability and the volume of the anterior chamber. In irrigation, it is the inflow of the BSS into the eye, governed by the pressure gradient between bottle height and negative pressure created by the aspiration ports. In advanced phaco machines, these machines have sensors at the phaco tip that allow active control of the intraocular lens by elevating the height of the machine. The intraocular pressure inside the eye is roughly 75% of the bottle height. If you have a too high bottle, it results in a high intraocular pressure, which might lead to iris prolapse, and this might injure the iris and result in further complications during the surgery as meiosis, a result of trauma to the iris. A too low bottle height results in unstable anterior chamber, which may result in injuring the cornea, iris capture by the phaco tip, and also meiosis due to the hypotony. It's preferable to have a higher intraocular pressure or a higher bottle height than a lower bottle height, unless you have complications, which we will discuss further. Then you need to lower your bottle height. What about aspiration? Aspiration, we have two modes in which the aspiration works. First, the flow rate, and second is the vacuum. And you use each one of these two in a different way while performing your phaco emulsification. Consider yourself drinking a drink, and you are using, while drinking this drink, a straw. If you are sucking the juice with the straw, you are creating the flow. As long as the fluid or the juice is moving inside your mouth, this is the flow. It is what comes from inside the anterior chamber into the phaco machines. It's the amount of fluid removed together with the emulsified lens matter through the aspiration tip. Once this aspiration tip gets occluded, then vacuum will start to build up, and you are changing into another mode. And this vacuum, you need it in order to grasp your fragmented lens matter, and in order to induce your division of the nucleus or doing the chop, you need to have a very hold grasp of this nucleus fragment in order to do the chopping, and this is utilized by the vacuum. So with flow rate, you are removing emulsified lens material from the anterior chamber and outside of the eye, while in vacuum, you are holding this lens either whole or part in order to do your dissection. It's like eating a piece of meat. You are using a fork and a knife. With the fork, your fork is your vacuum, and this holds the lens fragment tightly in order to be able to divide this lens matter. And once you grasp this divided lens fragment, you start your emulsification by utilizing the power and then emulsifying it and then removing it by using the flow rate after it emulsifies and it goes out of the eye. There are two types of pumps that are used with phacoemulsification. We have the peristaltic pump and we have the Venturi pump. And both pumps work differently. In peristaltic pumps, it consists of a roller compressing the silicone tube. This roller will turn in a clockwise fashion or an anti-clockwise fashion. It doesn't make a difference. But during this rolling of these systems, they compress the silicone tube of the aspiration system, and this movement allows aspiration from inside the anterior chamber through the tubes and outside into the collecting system. Peristaltic is a more controlled and it's slower than Venturi, and it's advisable for beginning residents to use peristaltic pumps, as Venturi pumps are much more faster and less controllable. So I believe that experienced surgeons should work with Venturi. However, beginners and even those who like peristaltic pumps and like to have more control during their surgery should use peristaltic pumps. Venturi pumps acts as a result of moving a gas into the tube. This movement creates a negative pressure of the flow rate, and the relationship of the vacuum created to the flow rate is not linear. The flow rate is normally between 20 and 35 cc's per minute. A low flow rate means better control. However, you have a longer surgery. A high flow rate means a faster surgery, less control, and you are more liable to induce complications if you are not an expert or an advanced surgeon. If you work with high flow rate and high vacuum, you are more likely to cause complications. So it's better if you are beginning your surgery to start with a low flow rate, something like 20, 25, a maximum of 30 to 35, and a vacuum of 250 to 300. If you are an advanced surgeon, you might need to, if you like, of course, to work with higher flow rate, reaching up to 50 cc's per minute, and a vacuum of up to 500 or maybe more if you need to perform your surgery in a faster mode. Modulation of the flow depends on the surgeon's expertise and preferences. Vacuum will only rise after occlusion. I'm sorry for the spelling mistake. Occlusion will start. Vacuum is the holding power of the lens fragment in order to start the emulsification and aspiration process. The phaco port size will affect the vacuum. The smaller the size, the higher the vacuum. Lastly, we are going to talk about the surge. It occurs during emulsification of a lens fragment as the vacuum builds up and the fragment is held tight at the tip. Once this fragment is emulsified, the negative pressure at the tip will fall instantaneously, resulting in collapse of the anterior chamber. Of course, in modern machines, this problem has been overcome, and by different processes, including venting, thick aspiration, rigid tubing, and delay in motor start after occlusion break. I think this is a start or just an introduction in order to show us how we have to be sure on how to work on the machine and we have to study our machine quite well, and to have to know exactly which setup and each change in each one of these setups will affect our working. What happens actually inside the eye is not only controlled by your hands, but it's controlled by the machine that's working beside you or behind you. So keep in mind to have the screen of the machine in front of your eyes. You have to change the setup yourself when you are starting your phacoemulsification, in order to get to know and be user-friendly with your machine until you know exactly which setup that you are going to work will allow you to work in a very relaxed mode. And of course, the synchronization between your foot and the foot position, you have to be acquainted quite well while you are going with your foot through position 1, in which once you step into position 1, you will start your irrigation. Step 2 will start your aspiration. And once you reach step 3, phacoemulsification, and all of the previous step will be already working with you. So you have to be quite acquainted and quite comfortable with both your hands inside the eye. Part of your mind is with the machine that's outside and delivering whatever needed parameters that control what's going on inside the eye. And finally, the foot switch, which is the violin that's tuning your work inside the eye while going through different positions, allowing different effects to occur inside the anterior chamber. And in the future sessions, we will discuss in details how we are working with different machine setups in order to work through different types of cataract, like Dr. Yahya showed us, of course. And I hope all of you who are watching will continue watching with us, as we are going to present in the future very nice and very attractive presentations in order for the young ophthalmologists and those who are venturing through phacoemulsification will get to know more about how you can move through different techniques in order to successfully perform the different situations that you are going to encounter during your phacoemulsifications. And thank you very much, and I hope to meet you all soon in with Dr. Muhammad, of course, in future meetings next year, inshallah. Thank you.
Thank you very much, Dr. Yahya. Sorry, Dr. Sharif. So you are both mixing my head today. Dr. Sharif, thank you a lot for this very, very nice and comprehensive and excellent presentation. And it shows step by step how can we deal with machines and what are the things that we should be put in our mind when we are starting doing. And I think my comment, if it's you allow me, this is not only for the beginners. We need all this information to remind ourselves. Even the complication can happen with those they are very expert. So because sometimes we are trying to do something as fast as we much, then we go and have complications. So I think it is very beneficial for everyone, not only for the beginners, to remember all these steps that you mentioned. And I think we can have more details about all this information you mentioned in our in upcoming episodes of Cataract, in upcoming webinars. Just if there is any question from any panelist here to Dr. Sharif, or from Dr. Sharif to another panelist. We would like to start with Dr. Zaina, if you allow me, our guest from here. Then Dr. Zaina, if you have any comments about this one.
Yeah, no, I thought it was a great introductory presentation. I think for residents and people starting out in surgery, it's so important to learn phaco-dynamics. A lot of the time, you just, when you're being staffed by someone else, you just kind of don't even ask these questions because you're so worried about the cataract itself. I always make sure that my residents have understand what phaco-dynamics are. And I think the key is that every single machine is very different. So for example, in one of my centers, we have the Centurion, the Alcon Centurion. So it's peristaltic. So everything that most people are used to peristaltic, and a lot of the data, a lot of the discussion is usually that. My other, surgery center, we have the Stellaris, and the Stellaris uses Venturi settings. And then also, we talk about pressing down on the pedal, for example. The Stellaris, not just as Venturi, but you can actually separate phaco power from vacuum settings. So you can have a different vacuum when you're pressing down and then kick to the right, yaw to the right with this. So you're adding a whole different dimension, which I think is really nice for some of these complex cases. The other thing is I wanted to kind of say, people always ask, so which, you use all of these, which is better? I think all of the new phaco machines now are phenomenal, and it's all about comfort and understanding your machine. And I think the concept of surge it's really less likely now. The surge was such a huge issue in the past. Now we have better tubing, we have smaller openings. And I think it's much less of an issue. And then the only other thing I wanted to kind of just express is, the concept of, peristaltic pumps, mention that you have to have full occlusion to get vacuum. And that's not the case for Venturi. And I'm sure we'll talk about it a little bit more, but you can actually get vacuum with Venturi even without full occlusion. So another major difference kind of between the machines. And then, sorry, the third thing that's new, or the two other aspects that are new and nice, is this concept of active fluidics, where you don't have to rely on the bottle height as much, and that you have these sensors, which again helps with the concept of surge. And then the nice thing is the new anterior vitrectomies ports can fit through 25 gauge now and go through nice paracenteses for bimanual vitrectomy. And that's just been so huge in terms of a benefit for our residents. So those are kind of the big picture sort of comments that I would have.
Thank you very much, Dr. Zaina. Dr. Safwan?
Well, I just need to add to Dr. Zaina related to the active fluidics. I think Dr. Sharif, he mentioned a lot of it. The sensors present and the bottle height, well, it makes the whole life, all the surgeons, whether the beginners or the experts, different, because we know that the important effect of the height bottle and the high pressure intraocularly on not only on the iris damaged and the zonules, but on the disc. And when we compare now what we are doing on a pressure of 30 millimeter mercury and the bottle height of 90, we can realize the difference between both. And now with the Century tip, I think that we reach to a 20 millimeter mercury. Anyway, that's need more details in discussion. But related to the again, one of the points that Sharif he highlighted, the foot pedal. I think that one of the important issues to understand for the beginners is the steps, because most of the beginners, they don't know that as Dr. Sharif mentioned it clearly, that the irrigation and aspiration and the power, when we start the third step, is the issues for changing and modifying our step, because irrigation, aspiration, and the third step, for example, in CHOP, what I'm doing is that I'm starting with the high pressure, with the high power, and then reaching to the zero at the end of this step 3. And this is totally different in reverse to the CHOP of the usual foot pedal that we were using. And I found that this step, by changing the power, making it start with the high, and then at the end of the pressing, you will have a zero power, because the power that I need is in the beginning when I hold in and holding the nucleus. Then I don't need power, because if I will increase the continuing pressing on the third step, then I will end up with rupturing the posterior capsule, or I need to return back. If I need more power, I need to return back up. So this step is very important to understand, and for any beginners anyway, and even for the surgeons, to change if according to his way of dealing with the foot pedal. For me, for example, I don't need to press to have the end of the third step high power. No, I need the high power in the beginning, especially in CHOP. And I found it very helpful. And if Dr. Sharif have it, he can use it, he can try it, or anyone, he can try it. It's very helpful, keeping the power in the third step for CHOP in the highest point and then ending to the zero. Apart from that, it was a very comprehensive lecture, dealing with all details related to the pharmacodynamics, and the point that Zaina highlighted as a difference between Venturi and peristaltic is that the holdability, which is the vacuum, and the followability, that the difference, especially in Venturi, you don't need to touch the nucleus to have a holdability, that the vacuum, but in peristaltic, no. We need to make the piece holding and touching the tip in a way that the holdability will start it, or the vacuum will start it.
Thank you very much, Dr. Safwan. I think what you elaborate, Dr. Safwan and Dr. Zaina, I think we are going to talk about in details in futures. So just now we are just highlighting, and we have only an introduction just to keep everybody tuned with us, and to wait for us for the more and more details. We don't want to give everything in once. So they can just now, like a course, we want to say, so everyone is learning. And I just repeat what I have said. This one, it's not only for the residents, it can be for all ophthalmologists. And in the high level, we are going to talk about complication, how to avoid, and so many things. So it will be a very interesting for all level of a surgeon or ophthalmologist, from the resident till those they are very expert. Is there any last comment from Dr. Yahya or Dr. Sharif? Then we can just conclude.
Thank you, Dr. Mohammed. I think this is a good start, yani, to put people, yani, to know what's important, but I don't need to stress more what Dr. Sharif was saying. And I always tell everybody who is starting, just you learn the machine more in wet lab, or even in the operating theater without the patient. Yani start the patient, your first case, after you master the sound using both hands, both feet, knowing how each stage is going. So this is very important. Facilitate, it removes a lot of the burden on the beginner surgeon when he starts his first cases.
Thank you very much, Dr. Yahya. There is a small questions also before we leave. We don't want to leave any questions. So how can I know the suitable height of pupil for each eye? I think maybe we will talk about this in detail future, but if there is any a short comment from Dr. Sharif.
Well, actually, in modern machines, the flowability inside the anterior chamber is more or less automatically maintained, but you can start with a bottle height of 60 to 90. And if while you are working, you find that the anterior chamber is collapsing, or that there is not much inflation of the anterior chamber, you can increase your bottle height more if you need so. This comes with experience while you are working, in order to maintain a balance between the inflow and the outflow outside the eye as well. What I want to emphasize here about this introduction, and this is a very important takeaway message for the junior staff, don't rush into cataract surgery. I know that everybody wants to perform cataract and successfully do his first cataract. Take your time getting acquainted, because actually what's going on inside the eye is controlled by different instruments outside the eye. Actually, it's the console and it's the foot switch. So know quite well how these different pieces of machines work together in order to succeed in performing the surgery finally. Take your time, and do not be sad that you are a little bit late in learning the cataract, because as much as it is important to perform the cataract, it's more important to know how each machine is doing its job, and to get acquainted with this machine very good. Thank you.
Thank you very much for all. It was very interesting, and I would like to thank every one of you for this a nice meeting with a nice comment, with nice presentation. And I would like to announce that we are going to have a meetings on Friday. It will be on 2nd of April. This is not an anterior, it will be a posterior, another format. So I would like to invite everyone to be with us, and we will send the invitation soon to everyone. Thank you for all. Thank you, Dr. Azena, Dr. Safwan, Dr. Yahya, Dr. Sharif, Dr. Brian, and also I'd like to thank Allergan for sponsoring this meeting, and thanks for our management event with us, Marvision, as usual. And good night for everyone, and good morning for you, Dr. Olga. Good afternoon.
Thank you.
Dr.
Thank
Azena.
you, everybody.
Thank you.
Goodbye.
Bye.
Bye-bye.
Thank you.
Bye-bye.